Good evening, everyone. My name is Jennifer Olmsted. I am the Senior Director of Governance and Operations here at the San Diego County Medical Society. In partnership with the Doctors Company, we would like to welcome you to our latest webinar and our last one for 2022, entitled Top 5 Risks for Your Practice. Our speakers tonight will be Kathleen Stillwell, who is the Senior Patient Safety Risk Manager with the Doctors Company, and Richard Cahill, who is the Vice President and Associate General Counsel, also with the Doctors Company. Now, before I hand things over to Kathleen, I wanted to just quickly remind everyone that tonight's webinar has been approved for 1.5 CME credits. I'm going to type the link to claim CME credit in the chat box, and Kathleen will also be displaying a slide that has a QR code that you can scan from your phone to claim credit as well. We have reserved time at the end of the program for Q&A. So if anyone has questions as we're moving through this presentation, please feel free to type them in the chat box, and we'll get them over to Kathleen and Rich once they have finished. And now I'd like to introduce Kathleen Stillwell. Kathleen?
Thank you, Jen, and thank you so much for inviting us. Rich and I are pleased to be here tonight, and we look forward to presenting this topic. As you mentioned, we are providing 1.5 credit hours CME, and if you want to use the QR square, if you have a smartphone, if you put it on camera, don't take a picture of the QR square, just hold it up, and then a little message will come up that says tap here, and it will take you to this screen, which is on my right, and that is where you sign in. You will put in your name, and please put your license after your last name, which is either MD or DO. If you're an NP, a PA, an RN, CRNA, put that. You will be able to get a certificate, and the nursing board and the PA board accept our credits for equal continuing education times. There will be, at the end of the program, the evaluation will come up on your phone, or you can do this all on a computer. Your registration will have your email address, and my assistant will push out the CME certificates within the next several days. And the truth is, she usually starts it the next day. We have a holiday Friday, so she won't be doing it Friday. As Jen said, our topic tonight is the top 5 risks for your practice. We are accredited, and we've disclosed that Rich and I are employees of the Doctors Company. I'm only going to briefly mention in my own bio, I am the Senior Patient Safety Risk Manager. I have a clinical background, 2 master's degrees in public administration and health services, and certified as a healthcare risk manager by the American Hospital Association. I think it's really exciting for Rich and for me to be with you tonight, because this has been another roller coaster year for healthcare. And as we're entering a season of gratitude, on behalf of Rich and myself and TDC, we are filled with gratitude and thank you for being there again through another year of pandemic challenges. Richard Cahill is our Vice President and Associate General Counsel. He is a very distinguished, experienced lawyer with a background of over 35 years in malpractice and healthcare law. He has got an extraordinary experience defending malpractice cases with some of the largest healthcare providers in California, including Kaiser, Tenet Health, and Cigna Health. I'm very pleased that I've been working with him for the last 15 years that I've been with the Doctors Company. Our objectives tonight, I'm not going to go over all of them, and we're not going to be reading everything on every slide. You have access to the copy of the slides. Jen will have them available for you. But I did want to point out that we want you to understand the priority of these risks and hear from us tonight strategies that you can implement to help reduce those risks. I always like to start with a thought of wisdom. And I went to Gandhi as I was preparing this presentation, and he wrote something that resonated with me. Strength comes not from winning. Your struggles develop your strengths. When you go through hardships and decide not to surrender, that is strong. And you might be thinking, I don't want to be any stronger. You're strong because you have survived the last 3 years. The pandemic impact has pushed you to limits that you never dreamed of. There's also been a major financial insult to healthcare as patients deferred care, and financially hospitals, healthcare organizations are reeling from what has happened. And while we have had lower hospital occupancy rates and critically ill patients have been shifted to other units, we're hoping that the fall and the winter does not bring us another surge. And of course, the front line of healthcare workers have been exhausted for over 2 years. And one of the most frequent calls I get out of my 400 calls a month from practices has probably 30% of them are due to, I have no staff today. My staff is out. They were exposed and they're out for a few days. I have no staff. So do you think malpractice is your biggest risk? Let's first look at why patients sue. They're dissatisfied with care. There's a lack of communication and rapport with the physician. Sometimes they say the provider had an attitude, and when I asked questions, I didn't get answers. I didn't get what I thought I should get. And these responses come from when we close out a claim, when then they ask the plaintiff, what brought you to court? Why did you want to sue? Well, I feel I was wrong. Also, many times people have unrealistic expectations or they're angry. They didn't expect a death. They didn't expect a complication. But most of our physicians get exonerated because you have good documentation. You'll hear more about that from Rich a little bit later. So what are the top 5 risks? Here they are. Do you see medical malpractice on the list? No, it's not. That's not your risk. Your number 1 risk is a cyber attack. I'm going to talk about that. Documentation issues. That's your second risk because your record is your silent witness. And if you're going to justify what you did, if you're going to defend your good care, it's going to be in the record. If it wasn't documented, was it done? Rich will address that later as well. HIPAA regulatory compliance is still on the list. It's dropped down. It used to be number 2, now it's number 3. So we'll talk a little bit about what are the types of problems we see. Then complaints to the medical board, that's escalating a lot. During COVID, that's the go-to place for disgruntled patients. And then negative social media posts. What are you going to do? That's your brand. What can you do? What will you do? Let's start with cyber attack. 60% of data breaches are from a compromised third-party vendor. That means it's not you, it's not your staff, it's one of the vendors you work with. They get compromised, and if they have access to your data, or there's a direct line into your data or your computers, if they're compromised, that's where 60% of data breaches come from. That is why, and I'll talk about it under HIPAA, you absolutely must have a business associates agreement with these vendors. And response plans are important. And if we could raise hands and say, raise your hand if you have a response plan in place if you have a cyber attack. I don't think many hands are going up. I talk to doctors every day and say, do you have a response plan? And they usually say, what does that mean? What am I supposed to do? My response is, I'm going to call you. Okay, well, that's a response. That's the beginning of the response. You do, if you're with the doctor's company, have a certain amount of coverage of cyber protection. And with other carriers, you have to check with your broker or with your carrier. But you do have $50,000 worth of coverage with our policy. And we give that to everybody. You have to evaluate the security of your third-party vendors. Be sure your office manager or your staff who works with the vendors and manages things is asking proof of their security assessment and what are they doing. And then this is a big one, and many doctors say, I've never heard of this before. Multi-factor authentication for computer access. What that means is it's not just a password protected, it's multiple. Now, I will tell you the doctor's company is Fort Knox. When I want to get on my cell phone, and I don't use a phone for work and a phone for business, I have everything on my personal phone. I'm required to have multi-factor authentication, which means I have a password, a thumbprint, or I could use face recognition. And then I have to have a code and an approval, 4 steps to get into my phone. And I have the same 4 steps to get into my computer. The most common cyber attack comes from compromised credentials. What does that mean? Cyber criminals scam organizations by getting into your business email accounts to see who you do business with. You may not even know they're in there. If you don't know what kind of traps there are that they can break through, and if your consulting company or your IT people don't have solid blocks so they can't get through, you don't know. The 5 main types of business email compromise that is behind cyber attack is listed here. A bogus invoice scheme. How many times do you get on your personal email says, yes, this is the final notice. You're having a renewal with Norton 360, $394 for a 12-month subscription. Please click here to complete your order. I would never touch that. I have Norton 360, okay? I have it, I know. I forward that to Norton's fraud line. Those are fraudulent. As soon as you click, they're going to be in your computer, and that's your personal computer. And I bet you don't have CyberGuard on your personal computer. And hacking into executive email accounts, compromising, and they love to impersonate as an attorney. And it might even be a law firm that you use and that you know of. You've got to look at the email address. There'll be something wrong with it. And then they hack into employees' email accounts. That's easy. Those are the top 5 things. So I'm going to give you an example. This was a real one that came through, and these are called phishing attacks. The most common cyber attack method is phishing. Today I sent 3 emails that were in my TDC inbox. I looked at it and I knew they were phishing. So we have a button to push that sends it to our IT department. So I don't click it. I get it out of my box. So this was, look at this. It was from the World Health Organization, and it had this My Health e-book zip, and it went on to talk about inside this book, you'll get all the complete research, all this about coronavirus. This looked so real. And the actually email was longer, and it looked so real. But a lot of people clicked onto it, and they got ransomware. They got taken hostage, their computers. And this had nothing to do with the World Health Organization. Here's an example where I say, don't be curious. Just look at this. This finance concrete. Now, this practice was doing some construction on a build out. So the person that opened it thought it was real because, oh yeah, must be a concrete. They didn't know. See attached file. Here's the zip password. Like, it's password protected. Let me know if you have questions. Yeah, their computers were taken hostage. And by the way, if CyberGuard attacks your computers in your office, to get them back is anywhere from usually 4 to 12 weeks or longer. And that's if you negotiate a deal and don't pay the full ransom. Ransom attacks, more than 1 in 3 healthcare organizations fell victim in 2020. I could not find the results for 2021 because they're not out and published yet, but this was just published at the end of 2021. And I want you to look at this 41%, not hit by ransomware in the last year, but expect to be in the future. Everyone should expect to be. What is the cost average healthcare ransom payment that we've seen? $131,304. Okay, you might have to crack into your retirement account if you didn't buy a $1 million CyberGuard policy. But I want you to look at the cost of data recovery. That's where the real cost is. The average, which means half is 50% is above and 50% is below, 1.27 million. Now, today, I don't think I'm not talking to hospitals. I'm talking about physicians' offices. We could have anywhere from 1 to 100 or more, 200 physicians in your office. But you really want to ask yourselves, What kind of CyberGuard protection do I have? What does it cost? Where do we get it? And I'm not here to sell insurance. We don't even sell it. The doctor's company doesn't even offer the $1 million coverage anymore. We refer you to another company. It's gotten expensive. I know I talked with a doctor the other day, a solo practice, and he said it was almost $3,000 a year to get $1 million worth of coverage. I don't know who he got it from. This is just, again, ransomware future. 63% of the people in this study expect to get hit by ransomware in the future. 37 don't expect to be hit. Well, the 37% are being naive. And if you expect to be hit, I'm going to tell you why you will be hit, because I see it from the calls I get. It's your staff. Your staff puts you at risk. How? If they're using your office computer on lunch break, on their personal break, if they're surfing the internet, if they're using it to do Christmas shopping, they're going on the Macy's website, anything, they're not in your network, they're outside of it. That's how people get into your computer, when they are on the internet. So the best thing you can do is to tell your staff, we have a new rule, thou shalt not use office computers ever. Personal use is prohibited. You can bring an iPad, you can bring your own laptop, you can use your phone, but you cannot use our phones. That is one of the biggest steps you can take for protection. The other thing is to implement multi-factor authentication for employees and yourself to access your computer. And this, I would just say, is the second most important thing. Look at the second bullet. IT experts estimate up to 90% of cyber attacks could be prevented by using MFA on computers and mobile devices. Don't you want to be in that 90%? Don't be in the 10% they're going to be attacked. And MFA is a minimum security measure. And people say, how do I do it? I don't know. You have to have your IT people can put that or tell you. If you have a IT consultant that helps you with your programs and your network in your medical office, they will be able to tell you how to do it. It's very simple. Recommendations, make plans, make sure you have reliable backups, deploy layered IT protection to block attackers. That sounds like I know what I'm talking about. IT people know what that means. But I had to include it because I talked to an IT expert. He said, Kathleen, put it in there and just say, your IT people know how to put a layered IT protection in to protect your office hardware and software. Anti-ransom technology is available, a malware recovery plan, and of course, the biggie is training your staff on email phishing, ransomware, and malware. Establish a security culture, protect mobile devices if you're using them. Be sure you have a firewall. Again, install and maintain antivirus software. That's your IT consultants. Use strong passwords and change them frequently. We're required to change our passwords every quarter. And we have to have something with a capital letter, a number, and a certain symbol. And we have to use a password phrase. We can't even just have a word. So it's got to be a very strong password. Now, with that, I am now going to move on to documentation, your silent witness. So I do a lot of medical record review. And if you're with the doctor's company, you can ask us to do medical record review for you. And this is really, to me, the most telling thing there is. Now, we don't come out to small practices, pardon me, but we can help you. So I wanted to show you some things that I actually found in medical records that I reviewed. And this first one was, patient is a disaster. Every time she comes in, constantly whining and wasting time. Okay, that was not the doctor who wrote that. That was the MA who wrote that. And I want you to think about this, because when there is a lawsuit, the medical record is your story. That is what the patient's attorney is going to get first. And by the way, with the advent of open notes that started in April 2021, and all unblocking was opened October 1st, last month, Patients go into their electronic records and they see something like this and they're not happy. This patient needs to find a new physician. I am done. Send dismissal letter. That was the physician wrote that in the patient's note. Not appropriate. Patient reports new partner only eats Mexican food. Patient suffers uncontrollable gas. Requests medication to control gas. Recommended new partner. Now, maybe that's funny, but not a good thing to go into a courtroom and put up on a giant electronic screen for the jury. They're not going to be tickled by that. That's an unprofessional comment to put in the medical record. Patient going on vacation, upset over episodes of loose stools, suggested brat diet, OTC, antidiarrheal, where depends. Patient said I was unprofessional, suggesting diapers. She plans to report me to the medical board. Told patient to find a new doctor. This is her last visit with me. Again, subjective comments like that do not belong in the record. And where it depends, maybe the doctor said it in jest. I don't know. I wasn't there. I didn't talk to the doctor who wrote it. I just read it. And I said, this is unprofessional. But you see, the patient was put off by it and said, I'm going to report you to the medical board. And the doctor just said, fine, you can find a new doctor too. That's like retaliating because she's going to report. As I said earlier on a slide, the top 5 risks, reporting the medical board is the 4th one. There's been a huge increase in that. Documentation is a reliable recollection of events. It's authoritative. It's contemporaneous, written at the time care was provided. Also remember, if you use an electronic medical record, metadata. It shows who documented and when. Every keystroke, every backspace, every delete is forever memorialized in the metadata. And when we have a malpractice lawsuit, I can guarantee you, our attorney and the plaintiff's attorney, they will ask for a copy of the medical records and they will ask for a copy of the metadata. Today, I had a very unfortunate situation where a physician called and he had gotten a notice of intent and a summons, and then followed by a summons and complaint within the last 30 days. And he was told, don't go back into the record and look at it. But he said, I did. And I added a little bit, but I put late entry so that it was seen it was added. Well, I said, I wish you would have called me before you did that, because that really can impeach the integrity of the medical record. And what we want to be sure is that you have the best opportunity to defend yourself. And so you want to be mindful about that in the record. A lot of different parties will look at your documentation. I won't go through all of this list, but I want you to see the press and social media on the right. Things get into the press now. Patients don't care. They're not bound by HIPAA. You are as healthcare providers, but patients are just fine giving a note that a doctor wrote that is inappropriate or subjective or would be criticized, to giving that over to the press and to putting it in social media. We'll talk a little bit later about social media. Again, consequences of poor documentation. It's a misinterpretation of care. And the other thing is, don't forget, your documentation is how you get paid. And delays or denied reimbursement, inaccurate or inadequate documentation is the number one reason cited for no pay or low pay. And I know you want to squeeze every nickel you can out of the value of the work you're providing. So be sure that you do. If you're seeing someone for an extended visit, don't just put a little short note in and the coders are going to only be able to code it for a brief visit. You might be leaving money on the table. Likewise, if you have a very long note, but nothing was accomplished, and is that going to really fit for a complex visit? And plaintiff verdicts in a malpractice lawsuit are very often tied to no documentation or poor documentation. If it's not documented, it wasn't done. Rich, can I ask you to speak up on this slide, because I really love what you say about it.
Thank you, Kathleen. Good evening, everyone. My name is Richard Cahill. I'm Vice President and Associate General Counsel with the Doctors Company. and I've spent more than 35 years in working with the healthcare community in a variety of different capacities. And one of the things that I've seen very frequently, and Kathleen has mentioned it several times during the course of her presentation, if it's not documented, the plaintiff's attorney will remind the jury that you're trained during the course of your education that if it's not documented, it was not done. And frequently, medical records are the absolute key piece of evidence in any type of malpractice litigation. And as Kathleen mentioned, for a number of other reasons as well, including regulatory compliance, billing, and so forth. But it's a legal document. It's part of your business record. It's made at or near the time of the event. And if so, it's independently admissible and can be reviewed by the jury in the jury room, and it will be posted on an electronic monitor during the course of the trial. So it's your key piece of evidence, and most likely may be the only information that you have to defend what it was you did and why. For example, frequently cases will not be brought for 2 or 3 years following whatever the allegation of wrongdoing was. And unfortunately, at that point, how many hundred visits have you seen in the meantime, particularly if nothing unusual happened during the course of the visit, you will not have an independent recollection. So if it's not documented, the plaintiff's attorney will claim that it wasn't done. We do have the opportunity under the California Evidence Code to show habit and practice, that if this circumstance occurred, here's how you ordinarily would have responded. And that can be important, but it's much better if it's actually in the record. You can rely on it both as independent evidence, but also to refresh your recollection. It supports continuity of care, what was done and why. In the event of a complaint to the state medical board, then we're seeing an increased incidence of those. What frequently happens is the medical board will immediately request a copy of the records. And as many of you are aware, they do not need a patient authorization, a subpoena, or a court order to get those records, because under HIPAA, they're government oversight. And as a government oversight organization, they have a right to see those records, and you can't object on the basis of HIPAA. Also, they're the primary witness to the standard of care that was delivered. In our cases, what the plaintiff has to demonstrate is that, one, there was a doctor-patient relationship, which usually isn't an issue. Secondly, that the care rendered somehow was not in compliance with what your colleagues would have done under same or similar circumstances. That's the standard of care component of a malpractice suit. And what frequently will happen is the plaintiff's attorney will hire an independent expert who will look at the records and say, I can see from the records what was done and why, and it was or was not consistent with what other physicians would have done under same or similar circumstances. Of course, they have to demonstrate, as Kathleen mentioned in an earlier slide, that there is a causative component between what was done or not done and actual damages. Also, frequently, and I did a lot of work with Tenet Health System over the years on billing issues, because frequently payers, and I also represented Cigna and Kaiser, would claim that there was inadequate documentation to support the coding that was actually used. And so what they will do, and as Kathleen has already mentioned, they will either deny the claim, or they will downcode it, or they will simply say, at this point, we have inadequate information, we need additional documentation. If it's done correctly the first time, that's in everybody's best interest. It expedites payment, and it avoids unnecessary delays. The most cited reason for non-payment by a third-party payer is that somehow the documentation was inadequate. So it's very important, whether it's for a professional liability claim, a malpractice suit, if you will, or an investigation by the state medical board or by a third-party payer, that you provide adequate documentation. What we have seen is that the vast majority of cases to the medical board, and that's a significant concern I think that practices now have, once the records are provided, in the vast majority of cases, that ends the investigation, and there's no further request by the provider either to provide a supplemental response, or no allegation is filed. So I think those are the principal considerations, Kathleen. Thank you.
Thank you, Rich, for that. The next slide on metadata I've really covered already, but I just want to remind you that it is forever and it cannot be erased. Amending the medical record, I want to mention, especially if you use a manual record, the concept of what's a late entry versus what's an addendum. And so what I really look at is looking at the standard that most hospitals use, and also Medicare, CMS. A late entry is something where the information is available, but it was omitted from the original entry. And you do need to put it, the date and time that you enter it, especially if it's a manual record. If you, in an electronic record, it will timestamp it when you did it. So it's immaterial. But the important thing is that it should be as soon as possible and the same day of the visit, or within 24 hours of the visit. That's a late entry. If you're putting something in after 24 hours, that's an addendum. And there you would just write addendum. And this is where information was not available at the time of the original entry. Sometimes it's you make a decision based on labs information you didn't have and you put something in there. So I would just want to say, don't call it a late entry if it's an addendum. Understand the difference between those two. In your office, if your patient comes in today and you told them something, and then in 2 days you got the lab report or the radiology reports back, and you have something, that would just be addendum to visit of date. And that's how you would do that. Copy and paste benefits and pitfalls. I got to talk about that, because the benefits are it reduces the need to re-enter the most common kinds of information, right? But there are pitfalls, and today's information is often, for the visit today, doesn't get added to the pasted information, or the pasted information might be outdated. It could be erroneous. Also, documentation landmines. These are the things you want to be sure you're not writing. And also, I want to say, if you have staff in your office that are documenting when they onboard a patient for a telehealth visit, they onboard them into the room, look at what they're writing. I see a lot, I frequently see MAs writing very subjective comments that are not appropriate for the record. So be sure that they're writing objective comments, not editorial comments about the patient. And we don't want lengthy self-defensive entries, finger pointing. Those are things that could be very challenging if you're involved in a litigation. Documenting difficult issues. I wanted to comment on this because what happens is, medication dependence and drug seeking behavior. One of the frequent calls I've been getting over the last year and a half is from family practice, from pediatricians, from internal medicine, saying, I'm prescribing scheduled meds for behavioral health issues. My patient, they don't have a psychiatrist. They can't find a psychiatrist that takes insurance. So I'm prescribing some scheduled drugs for their, maybe Adderall, maybe Ritalin, maybe some antidepressant drugs. And it's been going on for some time. And I said, well, what are you doing to document this? Because you want to be sure, if you're in that boat prescribing, that if there was an audit of your records, and it's very possible there will be, and I'll tell you about why there will be in a moment, but you want to be sure that you are documenting that you are reminding the patient, and also that you're reminding the patient to take the medication as prescribed. And you may opt to tell the patient, I've been prescribing this for the last year. I don't usually prescribe long-term. If we're going to go forward, then I am going to implement this agreement whereby you agree to these conditions of taking this medication, including random urine screening. This is important because I get so many doctors who say, I did the urine screen. I've been prescribing for a year and a half. And the last 2 urine screens, they came in and they're negative. They're not even taking the medication. What does that mean? What are they doing with it? They said they need it. So if anybody needs the form for that, a couple sample ones that some of the medical organizations put out, family practice, and those are on the internet. And if you would like it, if you send me an email, I'll send them to you. Inappropriate patient behavior we've talked about before, but I just want to remind you the most important thing is that you train your staff to use quotes around a patient's rude or inappropriate language on the phone or in the office, because they don't really do it often with the physicians at all. This is something that's going on with your staff. And the retaliation of patients to report to the medical board or to file a grievance when they're not happy about something at the doctor's office has probably increased, I'm going to say, by 80% during COVID from what I'm seeing. And what happens when they get the medical record and the note says, patient called for an appointment with Dr. Smith, advised Dr. Smith not available, offered an alternative, NP or urgent care. Patient raised her voice and said, in quotation marks, "You people are a bunch of GD idiots. Can't you even make an appointment? I only am going to see Dr. Smith," end quote. Rich, when the medical board gets that, or the grievance department at the health plan gets that medical record and sees that, what kind of influence does it have on the patient's complaint? That the doctor
Very significant influence, Kathleen. And when I first started doing this work in the early 1980s, and for many years thereafter, we discouraged practitioners from actually using terminology that somebody might regard as profane. What it tended to do was to soften it, and then at the time of a trial, deposition, or arbitration, the plaintiff's attorney would soft pedal that. The person would come across being well coached and would deny that anything untoward was said. If it's actually put in quotation marks, we've discovered that that is a very, very powerful piece of evidence, because as I'd indicated earlier, it's made at or near the time of the event, and it's considered very powerful as to what actually transpired during the course of the visit. And if somebody was using foul terminology, was disrespectful, what it tends to show is a pattern of behavior. And then when their credibility is an issue, and of course it has to be, particularly in a malpractice case or in an allegation against a practitioner in a state medical board investigation, what it does is it significantly reduces the credibility of the witness. And at some later date, somebody will look at the record and will say, well, that was what was said, and this individual was inappropriate. And it's very difficult for that person at some later time to try to recant that, because they'll say, I never said that. Well, that's a very difficult argument to make. And in my experience, plaintiff's attorneys, and more we're seeing that plaintiff's attorneys, particularly since MICRA was passed 35 years ago, are making a very careful evaluation of the patient and how the patient will present as a plaintiff before the trier of fact. And if it appears that there are repeated instances of inappropriate patient behavior or comments, not only will that have a negative impact in front of a jury, plaintiff's attorneys will look at that and may conclude that it's so difficult to overcome that it's not a case that they want to take. As Kathleen mentioned at the outset, we have a very good success rate in these cases, and probably someplace between 70 and 80% of all claims that are made against healthcare providers are resolved in favor of the healthcare provider. And a claim is simply a demand for the payment of money damages. And so if we see these comments in the records, an attorney likely may not take the case because the credibility of the patient or the patient's family is called into question at the very outset of the claim. Thank you, Kathleen.
Rich. Thank you so much. And so just to emphasize, train your staff. Don't ever document patient was rude and used foul language. That means nothing. Patient said, and put it in quotation marks. That's your golden ticket out of trouble. It also helps if you need to terminate a patient. Documenting a medical error is difficult. I don't get a lot of calls because there are not a lot of medical errors made in offices. Usually it's the wrong vaccine or it's an expired vaccine. Most offices have gotten away from having sample drugs, which is good because there's nothing good comes out of it usually. You have to document the lot and the number and everything in the patient's record. And if there's a recall, you have to have a way to find out. So you kind of have to keep a log. Disclosure issues when something happens. If you have something that happens and it happens in the hospital, you follow the hospital's disclosure rules. If something happens and there's an adverse event and a bad outcome, the doctor's company and other malpractice carriers have a disclosure policy and a disclosure procedure. We don't go over it because it's very rare you have to use it. You can call and we have an 800 hotline 24/7, other carriers as well, and they will tell you what their disclosure procedure is. What not to document? Hearsay. I had a doctor call me today and say, I have a patient who knows another patient I see that I prescribe a scheduled drug for, and he told me that that person doesn't take it. He sells it on the street, and I want to put that in the patient's record. I said, what are you talking? You can't do that. First of all, it's hearsay. Second of all, it's a HIPAA violation. You can't acknowledge that patient is your patient. And he said, well, then I'm going to confront the patient. I said, you can't do that either, because now you're breaking HIPAA to disclose that this patient told you. I said, instead, put them on a plan, and I sent him the form. They got to do the testing, and if they come back and they're not taking the med, say, I'm sorry, I can't continue with you. But we don't put hearsay, third-party hearsay in. Unsubstantiated statements, events that don't impact care, reference to legal action or incident reports. Some practices are in a group where you do an incident report, or if you do a first report with us, that's our incident report. You never would document, made a first report to my malpractice carrier. You would never mention incident report in a patient's record, because that is protected as a document that cannot be disclosed to the plaintiff attorney and to the courts as long as it's maintained the protection under 1157 evidence code. Remember to document your thought process and a differential diagnosis. Think about it. It's not often that you think, well, it could be this, it could be that, and you don't know. Maybe you have to get tests before you know. You might write, consider something, I don't know, whatever that something is, but showing your thought process, or uncertain of final diagnosis pending X-ray, MRI, CT scan, labs. That's okay to put. That means I haven't decided yet. I'm thinking about it. And remember, over a third of malpractice lawsuits are related to a diagnostic error, either a late diagnosis, a delayed diagnosis, a failure to diagnose, or a failure to refer. Those are the big ones for you. So remember that and think, should I refer this person to a specialist? Should I get a second opinion? That could be under your recommendations. And of course, you always want to document patients' response to treatment if you're doing education and follow-up instructions. This takes us now to regulatory compliance. And at this point, Rich, I'm going to turn it over to you to talk about HIPAA compliance.
Thank you, Kathleen. As I'd mentioned earlier, there are quite a number of concerns that you as practitioners have to address. For many years, I think the principal concern that practitioners had was the fear of professional liability actions. It has a significant impact on your practice, on your brand, and various aspects of how you treat patients. But I think of greater concern probably in today's world is regulatory compliance. There are lots of federal and state rules. There's, of course, HIPAA. And of course, in California, we have something similar called the Confidentiality of Medical Information Act that's set forth in California Civil Code Section 56. It sets forth all the requirements that you have to comply with to maintain patient confidentiality. Now, what are the most common HIPAA violations, which would also include violations of the State Confidentiality of Medical Information Act? Faxing to the wrong number. Frequently, faxing cannot be protected because it's not a secure method. Also, providing PHI on the phone without.
Rich, we lost your sound. Jen?
It looks like Rich has muted himself, Kathleen.
Okay, then he can hear you say that. Rich, can you unmute yourself?
Okay, is
There
that
you go.
better?
That
Yes.
Oh,
is.
real good. Thank you, Jen.
Yep.
It's very important that when your staff is talking to somebody, that they make sure that they have proper verification from the caller. One of the things that we occasionally see is that a patient make a complaint to the medical board, and the medical board will assign it to an investigator, and the investigator will simply call up and say, "Hi, I'm Bill Smith. I'm an investigator with the state medical board. I'd like to talk with Dr. Stillwell and get some information." And of course, that's something that we strongly request that you not take the call because it's unverified. You don't know who that individual is, and you need to have them put that in writing. And it's very important for your staff as well to make sure that they have verification as to who the caller is. And if it's not the patient, him or herself, then it's important to make sure that you have some secondary method of identification. Also, texting and or emailing patient without encrypted systems is something that's very difficult. And as Kathleen mentioned earlier, as of April of 2021, a federal statute called the Cures Act of the 21st century went into effect, and you have the ability to communicate with patients, and patients have the right to access the patient portal. And that would be a good way to communicate with them to ensure that the communication is properly protected and that there is not a violation of any type of HIPAA or state privacy statute. Inappropriate release of medical information. I probably see 200 or 300 requests around the country every year in which an office will get a request for medical information. Sometimes it's done by subpoena, sometimes it's done by a patient authorization, and you have obligations to comply with that. But also, there are certain requests that don't require any type of state summons, complaint, or subpoena. For example, if the medical board requests it as a government oversight agency, they're entitled to it. The same way with the Office of Civil Rights, the State Attorney General, and various other organizations. So particularly if you're a member of the doctor's company, make sure you avail yourself of the opportunity to send it to your risk manager, and the risk manager will make sure that we evaluate it to make sure whether it was proper and appropriate and whether or not it should be done. I had one come in today in which somebody requested information and the request was appropriate, but the actual issue was not whether they should provide information, but the scope of the information. Remember, HIPAA has a requirement that you provide only the minimum necessary to comply with the request. So those are very important when you get those to make sure that you have evaluated whether the authorization, subpoena, or other request is appropriate. And secondly, the scope of what it is you're being requested to provide and not to exceed the scope when actually producing either the documentation or other information. Social media. Frequently, we see issues where somebody will go on social media and they use it with impunity because sometimes they do it anonymously. Sometimes they actually provide a name. And the tendency immediately is to go online and respond and say, yes, I'm familiar with this patient, and then to provide an explanation. You cannot do that. Patients can put whatever they want online, and it's not a waiver of their HIPAA right, but you have to be very careful about doing that. And we actually have information available on our website as to how to respond to social media posts. It's something along the lines of, we are aware of the current post. Because of federal and state guidelines, we are unable to provide any type of written response. However, we always encourage patients to contact the office to discuss the concern, and we make ourselves available to meet with the patient as necessary to try to reach an amicable resolution. In the vast, vast majority of cases, that will end the interchange over the internet on social media posts, because what the patient is attempting to do is engage you into a public debate, which you cannot do. You want to avoid the possibility that that may result in an Office of Civil Rights investigation, which could have a lot of negative consequences, including fines, sanctions, reports to state medical boards, and so forth. What are the most common HIPAA violations that we've seen? Failure to perform a risk analysis, which needs to be done by every practice, as Kathleen indicated earlier. Failure to promptly release information to patients. Patients have, under federal and state privacy laws, a right to their information. And that became more acute as of April of 2021 with the passage of the open notes policy, which is contained within the Cures Act of the 21st century. You have to make that information available to them within a very short period of time so that they can access it, become familiar with what the diagnosis, treatment, and so forth was, and if necessary, to make any request that information contained in the open portal be changed, redacted, or otherwise altered. Also, missing patient signatures. Make sure that if you have consents and various other types of things that require active patient participation, that it's well documented the patient was advised and is necessary that the patient should sign whatever documentation requires his or her signature. This is a major problem, releasing information to an undesignated party. And I've seen this where somebody will call and say, my spouse was a patient of yours. She recently passed away. I'd like to get a copy of the records. I actually had a circumstance like that several years ago in which a husband called, wanted his wife's psychiatric records, claimed that she had since committed suicide. The practice very appropriately contacted the patient, said we had this unusual inquiry. The patient responded, well, I'm happy to report that I am alive and that the person that contacted you was my husband, and we're going through a nasty divorce and he's attempting to inappropriately get a copy of my psychiatric psychotherapy notes. And of course, the patient promptly advised her counsel, who brought it to the attention of the court. So it's very important that you only release information to a designated party, primarily the patient, unless there's some type of indication in the chart that someone else has been authorized. What are the most frequent HIPAA complaints that we see? Impermissible use and disclosure of protected health information. Once an investigation is conducted by the Office of Civil Rights to determine culpability, they will look to see what safeguards did you have to protect the patient from these inappropriate disclosures. And the better safeguards that you have in place increases the likelihood that it will be determined to be less culpable and less of a sanction or other fine. Lack of patient access to their HIPAA information. Patients have an absolute right to that, and if they request it, my recommendation is that you say yes, persist and consistent with federal and state privacy laws. We would ask that you put your request in writing, and if your office has a HIPAA compliant authorization, it's good to have them sign that and actually place the signed authorization in the chart to demonstrate that you were following due diligence. If you need to obtain one of those, you can go to our website and we have authorizations available for your download. Lack of administrative safeguards of electronic PHI. You have to follow under HIPAA the requirements with regard to privacy and security. Also, as I mentioned earlier, it's very appropriate when somebody asks for record sets, they will designate what information they want. And it's important that you only provide what's requested and nothing in excess of that. I've seen requests from practices in which a patient has seen numerous other practitioners, and for whatever reason, the patient has requested that prior practitioners' records be incorporated within the medical records. That's a practice decision that you must make to determine whether you feel those other records should be incorporated within your chart. But if somebody's requesting a record set, you have to be careful not to provide everything, simply what was requested. And as I'd indicated, I see an awful lot of subpoenas around the country, record requests and so forth, and frequently they will ask for everything, but not always. And we see them for a great deal of reasons, which include motor vehicle accident, professional liability claims, Social Security disability, life insurance applications, and so forth. So make sure when your staff is going through those that they're providing responsive, minimum necessary documentation. This is self-explanatory and I won't go through it, but there are 4 tiers of violations, minimum starting at $100 up to a tier 4, which is a $50,000 assessment per violation with a $1.5 million per year cap. These occasionally we see, particularly if there's been a violation of an insurance company, and we've seen those periodically, in which the Office of Civil Rights takes a very active, proactive stance and goes after somebody for violations, not just as a penalty for what was done in this case, but as a warning to practitioners and other health entities that have access to protected information to make sure that you're very careful and protect the privacy of individuals.
Rich, I wanted to make a comment on these penalties, because one thing that I think is important for the physicians to hear is the penalty. If it's $100 or $1,000 or $10,000, there's a maximum per year. But when they give this $100 fine, if you do one thing that's you did one person complain and you had one complaint, don't think you walk away with $100 fine. They multiply it times the number of patients in your database. And before you know it, you're going to be at a much higher number. The maximum would be 25,000, but I've seen them go over that maximum of 25,000. So it's pretty hard to deal with.
Thank you, Kathleen. And as Kathleen suggested, the fines and sanctions and penalties can be very painful. And here's some general categories, and I won't go over them because you will have access to the slides. But in medical practice, the right to access, in other words, somebody made a simple request for whatever reason, and for whatever reason they choose to ask for the records, they're entitled to them, whether they simply want to see the records, have it for future reference, whether making application for a state disability claim, or perhaps there's a claim for personal injury as a result. The amount in those circumstances was significant, over $32,000. Also, medical practices can be hit for a right to access or a failure to right to access. And I think it's very important that when those come in, you take them seriously. In California, particularly if it's a request by an attorney, you have a limited amount of time in which you need to respond. So take them seriously and respond appropriately, and make sure that the patient is treated with respect, because if they feel that they're not being treated with respect, several things can happen. One, everyone knows an attorney. There's several 100,000 attorneys in California, and sometimes attorneys will write a letter. Sometimes they will make a referral to a specialist in professional liability or compliance or regulatory issues. Sometimes they'll go to the state medical board, and as we'll discuss later, it's very easy to make a medical board complaint. Also, social media, they can make those complaints with impunity because they can say virtually anything they want. Yes, it's possible that at some later date you might decide that what was said was defamatory or libelous, but very difficult to make those claims stick. And in California, we've not had great results where practitioners have gone back into court to say this was false, defamatory, and injurious to my practice. So here's the HIPAA checklist that we recommend that you consider, and it requires 100% compliance. An annual security assessment of your practice. Make sure that's documented somewhere in an administrative file as to what was done, when, and by whom. You want to make sure that you have this, because in the event of an OCR investigation, you'll have the appropriate documentation to demonstrate due diligence. Also, make sure you have a HIPAA policy, and those are readily available. Laptop computers need to be encrypted. Occasionally, not frequently, but occasionally we see circumstances where someone leaves a laptop computer in a common space and it's stolen. And then you have issues because people try to access those and get the information contained. Also, make sure they're password protected. And as Kathleen indicated, multi-factor password protection is key, not only to make sure that the documentation and the protected health information is secure, but also in the event of a breach, you have an opportunity to demonstrate that you are acting reasonably and consistent with how your peers would have treated this situation prospectively. And I think finally, make sure that you have business associate agreements. Originally, the practices were responsible for everything. Now, some of the problems are shared with the business associates because in the event that they do something wrong, and as Kathleen indicated, 60% of data breaches occur because of a third-party vendor that you're doing business with. So make sure that you have business associate agreements signed with the vendors who may have access to your protected health information. This is a confidentiality agreement that we recommend that you have your employees sign. Another step in the process, both in the event of some breach at a later date, so that you can show proper due diligence. But I think in my experience, what it also does, impresses upon your employees that you take the security and privacy of your patient's protected health information very seriously. Once they know that they've signed this, that there are consequences in the event that something happens. And as Kathleen said, and one of the issues that we'll deal with later is what happens if you have a breach? You have to make sure that you have proper protection in place. And one of the things is to make sure that employees are not using office computer equipment for personal use, to surf during the lunch hour, to go online shopping, and so forth. Insist that they not use your equipment for personal uses. Maintain privacy for patient information. Make sure you do not share passwords. And when we first had an issue, and there's a separate statute in California called the Cures Act, which is a utilization review for scheduled drugs, we stressed the importance of making sure that you did not share your passwords with colleagues or anyone in the office, because what happens in the event of a problem, people get the metadata. And what they do is they say who is in the file, on what date, and for how long. And if somebody has your password, you will be held accountable to that. And that's very important that that not be allowed. Employee training is not optional. Make sure your staff understands what the requirements are. Make sure you do it first on the onboarding process with orientation, and then on an annual basis that's documented clearly, not only when it was done, what it was done, and who attended, so that in the event of a problem, you can go back and show, we did our due diligence, we did everything necessary, and this employee was properly trained and advised as to what his or her obligations were under federal and state law. Use online communication for unencrypted text and email, and we have a form for that. You want to make sure that patients understand that, and this is the form that we recommend that you consider using. This is available, and it tells the patient very clearly what can be used and how it can be used. Not only it avoids problems in the future, because the patients now are aware of what they've already agreed to, and in the event that some later time, there's not an issue about what they agreed to and not agreed to. And frequently patients will say, I just simply don't remember. If you have the documentation, it demonstrates what they were told, when, and the extent of their consent. This is another part of that form, and I think it's very important. Avoid HIPAA violations when you are emailing patients without encryption, and that's why the new statute of the Cures Act of the 21st century makes that fairly easy, because you can deal with them in your online office portal. Medical board complaints and investigations, and this is, I think, a serious component. This is when you go online, this is what you see, and you can see that it's very clear that the medical board, their design is to protect healthcare consumers. Their purpose is to make sure that the consumers are properly advised of their rights, and that if there's a violation of the rights, they have the right to go online and make complaints. And look how easy it is. Very simple. You push the button, file a complaint, everything comes up, and they're able to make a very, very easy complaint, and all complaints are investigated. Now, the majority of complaints are relatively easily resolved when the medical board investigator contacts your office and asks for a copy of the records. Simple. Ask them to put it in writing on official medical board stationery. I recommend that you do not talk with medical board investigators, but that you tell them to put whatever request they have in writing and have that done by a member of your staff, and make clear that you're happy to cooperate with the medical board, but you want to make sure you comply with federal and state privacy laws, and they'll understand that. We've had circumstances, and I had an unfortunate one in private practice, where a physician, prior to the filing of a professional liability case against him, actually had a medical board investigation. The attorney was involved with the complaint on behalf of the patient. The physician was attempting to do the right thing, made a statement to the medical board that I wasn't aware of, and that it was brought at the time of the malpractice arbitration hearing, and it had very detrimental effects. I wasn't aware of it. The plaintiff's attorney was aware of it, and it had pretty significant adverse consequences for the practitioner. These are the type of complaints that we see. The principal year was 2018 to 2021, and they've gone down since then. Difficult to know why, maybe having to do with COVID, but between 10,000 and 11,000, that's not a significant decrease, in my opinion. We'll probably see that go back up, or at least somewhere in that general range. What are the types and sources of the complaints? The public is the principal source. Fraud, health and safety, gross negligence, personal conduct. You can see that in this particular category, gross negligence or incompetence was the largest single type of complaint that people made. In large measure, in my experience over the last 35 years, has been that there was a disconnect somewhere in the communication between the practitioner and the patient. I had one arbitration I was talking with a physician about recently, in which the plaintiff's attorney had not conducted adequate discovery. And for the first time at the arbitration, the patient found out why she had a serious complication during delivery that resulted in a hysterectomy and sterilization. And when she found that out, she actually felt good that the practitioners had done everything right. But the plaintiff's attorney in that case, who was a very good practitioner, had not properly investigated it, had not properly had the records reviewed by an independent expert. So those are very important. Communication and documentation are key. Also, imposed while administrative actions were pending. You can see here the number that were sought and the ones that were granted. And you can see that it's a fairly significant number of cases, 67 out of a total number of 91, in which some type of sanction, suspension, restriction, or penalty was imposed. So if the documentation is not adequate to satisfy the medical board, they delve deeper, they request personal statements by practitioners, and they can escalate pretty quickly. Sometimes we see criminal actions or felony charges. I started my career in California as a deputy district attorney, and in those days, and this was the late 70s and early 80s, we didn't see an awful lot of cases that resulted in criminal prosecutions. There is increase in the frequency of felony charges having to do with billing fraud, improper prescriptions, and so forth. And what happens when there is a criminal action brought by a prosecuting authority against a practitioner? Inevitably, if there is a conviction, it will be reported. The Department of Justice can notify the agency. The physician must also report it under the Business and Professions Code. The court clerk and the prosecutor is also required to file a report. If you have further questions about that, I suggest that you Google California Business and Professions Code, Section 803.5. What are the most common causes for disciplinary action? Well, and we'll go over these in a little bit more detail in subsequent slides. One is gross negligence, which is defined as an extreme departure from accepted standards of practice. In other words, it's not just a mistake in judgment or something that was equivocal. Gross negligence is an extreme departure, or repeated acts of negligence, where there's a pattern and practice that's showing that the physician or other licensee is doing this as a matter of course of conduct, or clear evidence of incompetence. So what is gross negligence? Here's some examples, and I don't need to go through all of them, but not performing basic diagnostic tests that one would have expected of a licensed professional, not referring an individual to a specialist when, based upon the physician's education, training, experience, and the patient presentation, would indicate that a referral to a specialist was indicated, or not using acceptive or effective treatments or diagnostic procedures, or using diagnostic procedures or treatment modalities that have since either fallen out of use because of lack of value, or because they're no longer considered state of the art. The second category is repeated negligence acts. And negligence is defined as care that fails to comport with the community standard as established by other practitioners similarly trained and similarly situated. We used to talk about a community standard, but over the course probably of the last 10 or 15 years, it's actually a national standard. So what's done in a rural area should be the same that's done in a metropolitan area. I grew up in the central San Joaquin Valley in a small community by the name of Lindsay. The standard of care in Lindsay would be the same standard of care that you would expect in San Diego County. There are many ways in which practitioners can be aware of the standard of care through education, seminars, ongoing continuing medical education like our program this evening. It's expected that you will do what similarly trained practitioners in your area of specialty would do under same or similar circumstances. Also, repeated negligence acts may be sufficient grounds if it demonstrates a pattern of practice in which the practitioner is not doing what similarly trained colleagues would be doing under same or similar circumstances. And the final category that we were addressing is incompetence, lacking in knowledge or performing beyond training. And occasionally we see that in which somebody believes that they're wanting to expand their practice and they're attempting to go beyond what their actual training is. I'd had a circumstance a number of years ago in which a board certified ENT was going beyond practice and was attempting to do procedures beyond his training. And fortunately, he contacted our company. We discussed it. He then realized that perhaps he was attempting to do areas outside of his training. He then very appropriately went back and got appropriate training for the additional procedures that he wanted to perform. But it's very important that you stay within your lanes and boundaries and make sure that you're not going into areas of expertise that are beyond your education, training, or experience. So what are some of the causes that we've seen? And these are all pretty self-explanatory, and they're set forth in the Business and Professions Code, which defines under the California Medical Practice Act what you're obligated to do and what you're obligated to avoid doing. Obviously, sexual misconduct, substance abuse, violating drug laws, conviction of serious crimes. And as I'd indicated, once those crimes result in a judgment of conviction, they are reported to the state medical board and action is automatically taken by the Attorney General of the state of California. Engaging in kickback schemes in which somebody is participating in some type of a scheme with other practitioners or in the hospital setting or with third-party vendors. You have to be very careful about that. Be aware of Stark and the anti-kickback statutes, or allowing an unlicensed person to practice medicine. This doesn't happen very often, but I have seen it on a couple of occasions. I direct your attention also to a relatively new statute that went into effect, I believe, earlier this year, Business and Professions Code 805.8. And it simply states that a healthcare facility that makes an arrangement under which a licensed person, such as a physician or an advanced practice provider, is alleged to have committed some act of sexual abuse or misconduct, there must be a report in writing to the agency within 15 days. There are a couple of caveats to that, and we'll talk about those in subsequent slides. First of all, what is the obligation? Any written allegation of sexual abuse must be reported to the appropriate agency within 15 days of receiving a written allegation. It's only triggered by a written allegation. Somebody calls up on the phone or makes a casual comment in the office. If it's not reduced to writing, this statute is not triggered. However, if it is a written allegation, and if the allegation is only vague, having to do with sexual misconduct, it's better to err on the side of caution and make that report as required. This is an area that's something that's relatively new in California. I think it only went into effect earlier this year, but it's very important, and we're obligated as part of our continuing medical education programs to now include the reference to this. Individual personal cultures, systems of belief need to be taken in consideration with regard to education, race, gender identity, sexual orientation, ethnicity, religion, and income. Communication is influenced by the culture of your staff and your patients. It's very important to make sure that staff is properly trained and that you periodically have refresher courses with an opportunity for staff to voice concerns, questions, and observations so that there is good communication within an office, between practitioners and support staff, so that everyone is on the same page. Because if somebody on your support staff makes a mistake, you, as the owner of the practice or as a partner of the organization, will be held accountable. And these type of investigations usually will seek any type of written documentation showing that there were periodic meetings to address these issues. Another concern that I've frequently seen is questions involving interpreters. And in California, we have a great number of patients that have a diversity of cultural, ethnic background, and various languages are used as the primary language in the home. When talking with the patient, use a translator. Those are readily available, and Kathleen will make reference to it later. But the family should not be used to translate for a number of reasons. They may not do it accurately. They may be concerned about their own personal thoughts or agendas. And so you may not have an accurate communication between the healthcare provider and the patient. So avoid using family translators. Also, when you use a translator, document in the patient's medical record. For example, MA, and then use the initials, KS, familiar with the Farsi language, served as a translator during this visit. Also, for personal examinations, and it's not for the entire examination, just for personal examinations, make sure you have a chaperone present. And it needn't be for the entire visit, just for the personal portion of it. And if patients object to that, tell them that it's a requirement of the practice that you do that for their own safety and personal privacy. Also indicate, you could put MAKS was the chaperone, so at some later date, in the event that that's necessary, you were able to know that the MA was Kathleen Stillwell. And I think that's a very important thing to do.
Thank you, Rich. That's a lot of information. We're going to wind up here so we can get to our questions. We have a brief comments here on social media. You are in a customer service and a referral business. Train your staff to enhance the customer experience. When we look at customer experience scores and how patient satisfaction studies show what do patients like, they love staff in the doctor's office. And that's where you have an opportunity to ensure that they get a proper greeting, that they're told goodbye, thank you for coming in. And also train your staff to manage disruptive, inappropriate patients and also to document. We do a training on that if you're with the doctor's company, but other carriers do as well, because that's become a really centerpiece of problems, and it has exacerbated substantially during the COVID now 3-year pandemic. Get customer and employee feedback, and of course, treat complaints like gifts, because you don't know what you don't know until someone tells you. There's no such thing as social media privacy. Again, and Rich mentioned, your staff should not be friending with patients. They shouldn't be posting. They shouldn't be saying on their Facebook page, guess who came into our office today? And then there's a picture of a celebrity. And I will tell you, the celebrities, politicians, they all have consultants that glean the internet to see where they show up anywhere. And I have lost count of how many practices get a HIPAA violation because their staff documented guess who, and then they put a picture off the internet of that patient. And one was a practice, plastic surgery practice in Beverly Hills. And you basically are going to slam your business if people think that it's public or open to the public that they come into your office. Metadata posting can reveal private information on a photo. So if you're in a practice that uses any photographs, whether it's a pediatrician's practice, an OB, if it's a dermatology, plastic surgery, remember that there's metadata on photographs, and people can go onto your website and see the metadata and see the date and the name of the person. So be sure that your IT people are being very mindful of the metadata. Don't post anything online that you don't want to see on the front page of the newspaper. Rich already talked about don't respond, don't engage in arguments. We have some sample language that Rich created. If you're interested, I will tell you I'm not a fan of posting it because it just prompts the person to respond and get into a confrontation with you. But there are times that it is appropriate and it's helpful to post. But if the person who posts responds, we recommend you don't post anything further. Sir Winston Churchill said, "We make a life by what we get, but we make a living by what we get. We make a life by what we give." And again, I want to honor and thank you for all you give. You've been giving. You're still on the front line, and it's not lost on us that you go at risk every day, and that you've been challenged with staffing shortages and financial issues and getting supplies from the supply chain. We hope that it's a good winter and that the flu season and COVID don't take over. I want to remind you that you can get CME for tonight's program. If you have a phone with a camera, you can turn to camera, hold it up to this center scan image, just hold it up and it'll say click here, and then this phone front here will come up. At the program end at 7:30 on your phone, the evaluation will come up, and there will be, I think there's about 10 questions. Answer each one, and then you have to scroll to the very bottom to hit submit. You must submit it. If you don't have a phone or you don't want to do it tonight, you have until 5 p.m. November 16th. It will be available to claim CME credit. You can also, in the URL, type doctors.cnf.io, and it will bring up the screen on our website. What I'd like to do now, and you can be getting your CME scan in, but do we have any questions that have come in, Jen?
Kathleen, we do have a couple quick questions. One particular question for Rich. I'm concerned that if I refuse to speak to the medical board representative on the phone, it could be used against me. What should I say to them when they call?
First of all, my recommendation is that licensees not actually talk to them on the phone. It'll come through somebody in the office, and I think the person should simply say, we're always happy to cooperate with federal and state agencies. However, because of lack of our ability to confirm your identity at this point, we respectfully request that you submit your inquiry in writing on the official stationery letterhead of your agency, and we or someone on our behalf will be back in contact with you. If you're TDC insured, we have MediGuard in which something like that comes in. You simply report it to our claims department, counsel will be appointed, and the matter will be addressed. As I'd indicated earlier, I'd had an unfortunate incident quite a number of years ago in which a physician naively thought that talking to the medical board was in his best interest, and in fact it was not, because he made a lot of very unfortunate statements and concessions that had he had an opportunity to talk with counsel, he never would have made. So it's very important to not talk with them directly, to be respectful, to indicate that you're willing to cooperate, but that they need to confirm their identity in writing on official stationery, and that you then contact your professional liability carrier to see if there might be coverage to assist with the appointment of counsel so that your rights are fully protected.
Got it. Thanks, Rich. Kathleen, one other quick question for you before we end. How often does a physician's office staff need to have HIPAA training?
That's prescribed by the federal and state HIPAA laws. They must have training at the time of hire. That means before they start working, or if they're on their first day, they do the training before they start into the tasks of the job, and they're required to have an update annually. We have slides available. We have free on-demand HIPAA training on our website. It's 24/7. You don't have to even be insured by the doctor's company to attend any of our on-demand training that's on our website. And so that's, if you have someone who comes in and works part-time and they say, well, I had HIPAA training at my last job, then you need to have a copy of their certificate, and you must put it in their personnel file. Just them saying I had it already is not adequate, because if there's a HIPAA complaint, there's 3 questions you will be asked. There's been a complaint about patient asked for the records and you didn't give them to them within the prescribed time, because that is the most frequent complaint. But they still will ask the same 3 questions. Please provide us a copy of your policy on release of information. Provide information on the last HIPAA training for your staff. And the third one, that they will ask you to show you what the training, they may ask to see what was the training, and they're going to ask you, when was your security assessment? They're going to ask that security assessment every time. So that's why we mentioned it earlier. You need to do an annual security assessment. There's a tool on the Health and Human Services website that you can also use to do that. Do as much of it as you can, or have your staff do it. And then you can, some of it's IT, so an IT knowledgeable person has to do it.
Terrific. Well, thank you. I think that is about it for our questions. I would like to thank everyone for joining us this evening. Of course, thank Kathleen and Rich for another fantastic presentation. I did mention in the chat box, if anyone would like to receive the slides, please send an email to sdcms@sdcms.org. If anybody has suggestions for future webinar topics, we would love to hear those, so please send those to us as well. Lastly, if you are a physician here in San Diego and not yet a member of the Medical Society, I would encourage you to visit our website at sdcms.org, where you can find out more information on membership, and you can quickly and easily join online. Thank you, everybody, and have a good rest of your evening. Good night.